Welcome to Docs on Call, brought to you by Northeast OBGYN.
Good evening, I'm Lee Kelso. Thanks for joining us. Tonight we're going to adopt a rather hopeful outlook on what is really a sad event, the loss of a pregnancy. Despite all the advances in modern medicine, miscarriage and stillbirth still do happen. Why is that? What goes wrong? If you've lost one pregnancy, are you at high risk of seeing it happen again? Are there treatments to help improve the chances of a successful pregnancy? And what's available to help deal with the grief and disappointment after it all happens? Well, those are the topics that we're going to cover tonight with our guest, Dr. Jeffrey Cly from Northeast OBGYN. Good to see you.
Thank you very much.
Pregnancy loss is a pretty broad sort of umbrella term. What are we really talking about there?
We're talking about first trimester losses such as a miscarriage. We're talking about mid-trimester, around 4 to 5 months of losses before the baby can live outside the womb. And then we're also talking about late term, which are very difficult and tough, is right before the baby's due and can survive, that it doesn't make it, it passes away inside the mother.
Mm-hmm. Miscarriage is something that people keep very quiet and very private often, and it happens much more than people imagine, doesn't it?
It does. It happens about 30% of all pregnancies, even if that's a really early pregnancy that was just made a few days ago. And what we've found over the last several years is that there's so much new technology and understanding about the miscarriages and pregnancy loss that much of it can be prevented, and by using different medicines or treatments, we can help women have a baby, a successful baby, and not go through what they may have gone through, or prevent it from happening to them in the future. So
many women may have had a miscarriage and never know that they were pregnant.
That happens a lot. A lot of women kind of think something's going on, and that's a very early miscarriage, and maybe it's only a week that their menstrual cycle's late. But a lot of times they'll come in and say, I think something happened. I think I was pregnant, but then I had my period. And so we'll kind of look and see what we can determine and how we can help, because many times we can. And that's the message, to really let people know that there's hope. And it saddens me when I hear patients say, I've had 5 miscarriages and my doctor said, I'm just not meant to have babies. And that's the person who there is something going on, and we can make a difference for her.
If you have questions about this topic tonight, we'd sure like to hear from you. The number is 483-8331, 483-8331. Jump on the phone tonight with your questions for Dr. Jeffrey Cly. So if I come to you and think that I've had something happen, I've had a miscarriage, you may be asking me about my parents' stroke and heart attack. What's the connection there?
Some of the new research in the last few years has shown that there's inherited enzyme deficiencies, or let's say vitamin deficiencies, that come from parents, one or both parents, that relate to causing miscarriages. And what happens in the family is heart attacks, stroke, blood clots in the legs or the lungs. And a lot of that, if you have family members who've had those issues, that's a tip-off that you might have this enzyme deficiency that's inherited, that we can change and we can fix by doing different treatments, different medicines, or different vitamin therapies.
You just told me a story about one particular patient. Expand on that a little bit more, and what you found in her history and how you were able to help her.
Well, the patient we had a few years ago came in with a last trimester loss, and a baby was a stillbirth, and everything had been normal, and it didn't make sense to me either. And going through that with her was horrible, and we started looking, I started learning and researching, and I found some of these things that I'd never heard about that were brand new back a few years ago. Some new discoveries about something called MTHFR in particular, which is an enzyme deficiency where the blood clots in the placenta, and even though everything else is normal in the patient, the oxygen and the vitamins and nutrition don't get to the baby. So what we found through then looking at her family history is that there were issues in her family with strokes and heart attacks, and even going way back to a grandma who had several miscarriages. And when we looked at that, we found that she had inherited enzyme deficiency that came from one of her parents, and we were able to track that and treat it, and she's gone on now to have several children successfully without any problems.
That's a great story. I've got a lot of other questions, but really this program is for you, and Stephanie, I think, is our first caller up tonight. Go right ahead with your question for Dr. Jeffrey Cly.
Yeah, hi, Dr. Jeffrey. My question is, I've had 2 ectopic pregnancies, and they both ruptured both of my tubes. I had them within 3 months of each other. What and the first one that I had, I was 14 weeks along. What, nobody can really answer me what causes that.
With the tubes, there's a good thing, but there is some question on tubal pregnancies. Is there something going on in your system that's causing it to get stuck in the tube? It could be something in your tube, and so I would say make sure that's evaluated anatomically, either x-rays or some testing to see if the tube is flowing well and fluid flows through the tube. But also I would look at some labs that look at your blood system, your immune system, to see if you have anything inside the system that's affecting the blood flow around the pregnancy as it's growing, because that could be easily the factor. Insurance covers these tests as well, especially if you have someone who has a family history or you've had a history yourself of pregnancy loss or ectopic pregnancies. They'll cover those tests because we have a reason why we're looking. And it's a simple blood panel, and the results are done here in town for the most part, a couple % away. But don't give up hope, because I think there's a good chance you might be able to find out what's going on and then try to change it by different techniques depending on what it is, and monitor very intensely next pregnancy to make sure things are working smoothly.
Thanks
Go
ahead, Stephanie. Go ahead.
Right. My thing is they had to cut both the tubes. I am no longer able to have children.
Okay.
Because of that, unless I would have like in vitro or something like that done.
Right. Yeah. I'm sorry to hear that, but that's true. If it sounds like they determined that the tubes were damaged and would cause a problem every single time you would get pregnant. So they were trying to save potentially a life-threatening situation for you. But you are right that the in vitro technology would allow you to bypass the tubes to become pregnant. And there are some doctors in town who you can talk to about that aspect of things. But still have the testing done to see if there's something else going on that caused the tubal issue in the first place.
Right. And how long does the side effects of the mental side effects, how long does that last? With not, I mean, like I can't even look at babies now. And this was over a year ago that the last one happened. I have a very hard time with this whole situation.
Yeah, I agree. I'm very sorry. I would say to definitely talk with your doctor, but talk with someone who specializes, like a counselor. We work with a few counselors who have been through this themselves and help women all the time to move past this, because it's a loss. It's a loss, just like losing a family. It is a family member, but losing your mom or your dad, your brother or sister. So there's stages of the grief, and it takes time. So don't give up hope. Talk with your doctor about seeing someone who does some counseling, and you can even call us or call after the show, and we can give you some names and numbers. But I would agree. Keep trying to move forward, because you can do it.
Okay, well, thank you very much.
Thank you.
Thanks for your call tonight, Stephanie. We talked earlier about enzyme deficiencies, but there are other factors that can come into play as well. What role do hormone imbalances play in creating a pregnancy loss?
In the beginning, the woman's ovaries support the pregnancy with her hormones until the placenta and the pregnancy make its own hormones. And so what we found is many times the patient will get pregnant, the first few days, everything's going well, but her ovary won't make enough progesterone, for example, to support the pregnancy. So if we supplement her with progesterone, when we find this is the case, until around 10 to 12 weeks, when the pregnancy and the placenta and baby make its own progesterone, then that'll prevent a miscarriage. It happens many times, and the way we detect that is during the time after a woman ovulates, we check those levels, and we can see that this is what's going on. Or if she just finds out she's pregnant, we'll usually check a progesterone level right away. And if it's low in the first few weeks, we can also supplement and change that so that the baby will do well.
And this is a test that you'll run irrespective of their history, so I may not already have lost a pregnancy. This is just a standard process you're going to check?
Yeah, many times, not every time, but many times I'll kind of look at this clinical scenario. A sign that a woman's hormones are normal: nausea, breast tenderness, maybe she's feeling a little bit of stretching growing pains. That tells me things are working well. But maybe she comes in and says, I'm not having any nausea, I don't have any symptoms of pregnancy. Many times there's something that's not flowing well or going well, so that's what a woman will test, even if this is her first pregnancy. But I don't want to scare people that if you're not nauseated, that there's
right.
a problem. But we kind of look at the clinical picture.
How is your mindset different than maybe when you just left your training and started the practice? It sounds like you've learned a lot and grown a lot and developed a lot of new awarenesses.
I found through some challenges and difficulties, and even in trusting docs in my own life, in my family life, that I've got to look outside the box. I can't just accept what that research paper is telling me today, because all too often I'm finding that we're treating the lab result, or we're treating based on one research paper from 100 patients or 1,000 patients. And I'm finding that we have to do what we went to do in medicine. I got into medicine to help people. Mm-hmm. I got to remember, okay, I've got to look at every single thing. And so I think that's how I've changed. I try to look at the whole picture. I want to look at the patient, her lifestyle, what's going on around her, what's going on inside her body, to really come up with the right path to have the best outcome for her.
If you're just joining us, we're talking with Dr. Jeffrey Cly about pregnancy loss. Miscarriage, stillbirths, what causes it. There is some hope out there, lots of interesting treatments that can help you get that successful pregnancy that you've been hoping for. If you've got questions, it's 483-8331. Well, you just mentioned you're going to look at what's going on in the woman's life. Are there conditions that have no symptoms that I would know absolutely nothing about that could put a pregnancy at risk?
There are some conditions, and there's still some things we don't know, of course, yet. And so those are the times when it's very challenging, because you think of everything you can think of, and you just can't figure things out. Luckily, those times are getting less and less and less now. And so I try and paint a picture for the patient, and I try and say, okay, you're pregnant now, and I find that most women are working, especially if they're not pregnant or they haven't had children. Might be working, might be taking care of their partner, their husband at home, might be doing a lot of things, and I try to remind them that in addition to all that they're doing, they are creating a human being inside, and they're really pushing their body hard. So we try and talk about, through this next 9 months, I want you to remember that at the end of the day, when you come home and you're exhausted, you're still making that baby. So maybe we have to cut back on work, or maybe we have to cut back on some of the stress if you can, or we got to talk to the partner about helping out a little bit. But just try to find a balance for patients, because so many patients are running around and they get home from a 10-hour day and they just can't stand up anymore.
Sure.
That to me says they might be doing a little too much, at least for this 9 months.
You told me earlier about a low thyroid condition that kind of flies under the radar and you might not notice and can be kind of dangerous. Tell me about that.
Yeah, thyroid is very common. Sometimes up to 10% of women have an underactive thyroid, and thyroid controls the metabolism in the body, weight, fatigue, energy, skin, bowels, and pregnancy. And if a woman has a thyroid it might be in the normal range, but it's on one end of normal, it could cause her to have a miscarriage or not get pregnant. And I see this all the time, and they really don't have many symptoms at this level, but they just can't get pregnant, or they have recurrent miscarriages. And a lot of times if we just give a little bit of thyroid hormone medicine just to get their level smack dab in the middle of normal, that takes all of the problems away, and they do well. They finally feel a little bit better. They didn't realize they may not have been feeling tip-top, and the pregnancy, they get pregnant and the pregnancy flows well.
If you lose a pregnancy up to about 20 weeks, it's considered a miscarriage. Beyond 20 weeks, it's considered stillbirth. Are there different conditions that are going to pop up and become dangerous in that in the later portions of the pregnancy?
It can be different conditions, and it can be the same condition affecting the outcome differently. But very commonly, it's maybe a structural or anatomic problem after 20 weeks, like the cervix, for example. The cervix might dilate early. It could be the patient has a collagen deficiency where her cervix can't stay closed until she goes into labor at nine months. Or it could be she had a procedure because of some abnormal cells on the cervix a few years ago, and that's weakened her cervix. And so I really try and pay attention very closely during those times when a woman comes in with certain complaints or issues. And sometimes just a minute or two of preventative precaution can make all the difference in the world for the patient at the end.
Whether I've got a history or not, what are some of the action points in a pregnancy, things that I need to look for, that I pick up the phone and I call you? Because I know lots of women are hesitant. They, you know, oh, it's probably nothing, talk themselves out of calling, or don't want to be a bother to the doctor's office. What are some of those points that I absolutely need to pick up that phone?
Sure. Infections are a good example of that. So a woman who feels like she's having some issues, may have an infection, like a yeast infection or bacteria. Let us know, because those can cause cervical weakening and cervical dilation. Instead of waiting 3 weeks to your next visit, give us a call. Spotting can be an issue. Most people do get concerned about that, but there's some women who have been pregnant several times and are like, oh, that's okay. Let us know about that. And I'll usually talk to the patients about what to expect, what aches and pains are normal, what are not. But if they think there's an ache and a pain that's not normal, let us know. And I often get calls, and I smile because I'll get a call frequently. It's between 6 p.m. and 8 p.m. at night, and a woman, maybe in my practice or my partner's practice, says, "Doctor, I've been having this all day long." Well, so by that time, we've got to have her go to the labor and delivery, and it's a little more expensive and time-consuming. But if you're having complaints throughout the day, give us a call, and we'll give you a note for work, but we can have you come into the office and check things out before it gets ahead of the game.
We've got Tina on the line tonight. Go right ahead with your question.
Yes, I have a friend of mine has had several miscarriages over the past several years. I think she might be pregnant right now. Is there a tactful way of asking her if she could be without being embarrassed?
That's a great question, and I think the important thing for people who are listening, men, women, friends, family members, is if you know someone who's struggling, let them know that there is probably hope out there, and there's something that probably can be done, not to give up. So if she's had miscarriages and she's struggling and it has not been addressed, she is probably scared out of her mind this pregnancy. And so maybe actually just by saying, hey, you heard this guy named Clyde talking on TV about this issue, might actually help her have someone to talk to, and she might feel relieved that you cared enough to ask her what's going on with her. And you don't even have to get into the details, because she could say, I've got it under control, everything's okay, or she could say, thank you so much for asking. And she could call our office, or she could check with her doctor and say, hey, I've had these challenges, what do you know about this, or what can we look into? And so I think you're doing the right thing by calling. And I talked with someone last night at the hospital about this, and I said, you got to do the right thing. You got to tell this person this issue. And she said, oh, I'm too nervous. I don't want to make her upset. And I said, well, is it the right thing to do? And she said, it is the right thing. I said, if you do the right thing, then it doesn't matter what happens after that, because you've done what is right and just.
Thanks for your call, Tina. Diane, you're up next. Go right ahead with your question for Dr. Jeffrey Clyde, that guy named Clyde, as he just said.
Yes, my question is, I have a daughter. This is her first child, and she's not here in Indiana, but she's in L.A., and my question is, she has a real problem with dehydration, and recently was in the hospital because she can't keep anything down, in the hospital for 2 nights with IV, and looks like she may have to even have a nurse come home with her with an IV. And I'm just wondering, what causes that, and what can be done when it's that extreme?
That's a great question. That's a really tough problem. It sounds like hyperemesis gravidarum, which is severe nausea and vomiting in pregnancy. And we get a few people a year who have it so bad that they've got to have IV and medicine throughout most of the pregnancy. And sometimes actually they have to be fed through the IV. We have someone right now who's struggling with that. And so prayers are always good, because that can only help. But it sounds like her doctors are on top of it, because we try to make sure that the patient has enough nutrition and enough hydration. And actually the babies are very resilient, and they can take any nutrition the mom has from the system through the placenta and get nourished. So usually the babies are fine throughout this severe dehydration. It's the moms that are having the hard time. And ultrasounds, which I'm sure her doctor's doing, will verify that the baby's growing appropriately. And so we'll do that through the pregnancy and make sure the baby's growing good. And once they deliver, the patient, your daughter, should do fine. There's a chance it could go away before she delivers, and we always hope for that. But sometimes it does take the whole pregnancy.
Oh, okay. All right. Well, thank you.
Thank you. Thanks for calling. What happens that some women can coast through pregnancies and others have that type of just ongoing struggle. Is it an imbalance in the chemistry of the fetus against the mother, or what's causing that?
It's a fantastic question, and we don't understand it completely. We do know that there's a paternal aspect to it, and which is very interesting and confusing, because
so you mean the chemistry that the father brings to the table?
Yeah, has a factor, and how that happens we don't know, because the baby's supposed to be sealed off in the amniotic sac, but that we see that all the time, especially with the miscarriage risk too. So maybe someone's had several pregnancies with no problems, they get a new partner, something happens, and now they start struggling. There is a paternal aspect, and we don't know how it works. Usually the mom still has some issue that is uncovered, but when you add that whatever gene from that dad, it triggers it. And the same with hyperemesis too. But it's all the hormones and the extra metabolism that's going on. It's too much for the mom's system. And even though the baby's doing fine, her body just reacts with this severe nausea and vomiting, sometimes the whole pregnancy. Usually the first trimester is when, and the hormones in the first trimester drop off after around 13 weeks. And that's why most people do better after 13 weeks. But some moms, just even a little bit of hormones still affect them.
Wow. Ebony, what's your question tonight for Dr. Jeffrey Cly?
I just had surgery this morning, actually, for endometriosis. It's about my sixth one, and actually go to a doctor in your office, and she's wonderful. What is your plan as far as how to get rid of it? I mean, I've had a laparoscopic. They're going to start me on a hormone shot. I've already had a hysterectomy, and I'm 31.
Start us out with an overview of endometriosis.
Sure. And endometriosis is the menstrual tissue that's supposed to come out every month with the period. It gets stuck inside the body cavity, around the bowels, around the uterus, around the ovaries, and causes scarring and pain inside. And so women, when they have a period, they're having a period inside their body as well, all over, and that causes a lot of cramps and pain. Well, the only thing that I would make sure that they've initiated is some bladder therapy and checking. Usually 60 to 80% of the time with endometriosis, a chronic bladder condition also runs alongside it. And so that can trick us a lot, because it's right next to the uterus, the bladder, and we may think it's your uterus, but really it's your bladder that's also being affected right now. So one thing is make sure that your bladder's been evaluated, and if it hasn't, talk to your doc and say, hey, check this out, do you mind? And
what are they looking for? Endometrial tissue inside the bladder?
Actually, it's more of a chronic inflammation. It's like a redness and inflamed bladder, so it's not actually endometriosis. So we don't know the link, but there is, again, that connection we don't quite understand, but we know that different types of foods and acidity and vitamin C, for example, will trigger it. So if you treat the bladder, treat the endometriosis, and then they probably have you on suppression, but try to suppress the endometriosis with frequently progesterone. Those usually will result in a lot of symptom-free time. Unfortunately, endometriosis always tries to come back, so you're always going to want to stay on top of it somehow or another until someday we find the cure. We don't know how to remove it so that it never comes back, but we know how to get rid of it for the moment and try to suppress it.
Thanks for your call tonight, Ebony. I think it's Jenny, is that right? Are you up next?
Yes.
Go right ahead.
I have a question. I have HR factor in my blood, and I'm wondering if I could pass that on to my children.
Tell me the factor again.
HR factor in my blood.
I'm not sure. Is that a blood type? I don't know if I've heard of HR.
I have A negative with the HR factor in my blood.
Okay, so yeah, you've got it's a type of blood you have. And there's there's A blood, B positive, O. There's positive, negative, and that's a rhesus, Rh positive, Rh negative. But there's other factors that we don't usually check for that are a little more unusual, Kell, Duffy, and they can be an issue, or some of them are not an issue. So yes, you will pass yours on to your child. Your partner will pass his on to the child, but the child could have your partner's blood type. So there's no way to know until the baby's made and you check their blood type after they're born. But they do have a chance of having completely your blood type, which would be 25% chance just by the way the two come together. 50% chance it could be a mix of your partner and you, and 25% chance it could be your partners.
Thanks for your call tonight.
Thank you.
You know, as you've been answering those questions, it's occurred to me again, it's really kind of fascinating this process works at all, isn't it, with all the risks and variables that happen here? What in your practice has surprised you the most in that way?
I guess when I think of that, and that's where I smiled a little bit when you asked earlier how I've changed, and what I found is that, you know, doctors are human too. We're very busy, things are getting busier all the time, and sometimes the rat race can easily let you miss things. So we have to take a second, stop and look at the patient, look at what's going on, and slow things down to make sure we're doing the right thing. But also I said, okay, a million things have to go right for a baby to be conceived and delivered. Well, there's got to be more than chance for a million things going on. And so I find it hard to accept that so many pregnancies just miscarry just because. And so that's, I think, what a lot of us are finding, that old thinking is no longer valid, that there are things that are occurring, and we can many times find out how to give that patient hope, how to let her know and walk her through the pregnancy, and that she's going to take home a baby and going to hold that baby and have a family. And so that's what we want to let people know, is there's hope out there. We can make a difference. Don't give up.
That's great. And very quickly, because we're almost out of time, if you feel as though your doctor isn't really hearing your concern along those lines, what do you do?
I would, as patients do for me, if I'm not listening, say, Doc, wait a second, please, let me just say this again. Here's what, you know, can you help me? And just stop your doc, and we want to help you. So don't be afraid to say, wait a second, I don't think you're getting this, because we want to do what's right for you.
We've got to leave it there. Thanks very much, Dr. Jeffrey Clythe. Thanks for all your great questions. We'll see you next time around here on Docs on Call, and you can always visit us online on docsoncall.tv.